Okay, so I'll start off with the cocci. Okay, so in the cocci, we'll be discussing about three main things. One is Neisseria meningitis, Neisseria gonorrhea, and Moraxella catarrhalis. So let me start off with the Neisseria. Okay. So first of all, these are obviously the name, like they are like gram-negative diplococci. Diplococci. Diplococci in the sense there will be two cocci always together like this. Then where do they grow? Because this is another important one. There are very few bacteria which grows in this agar. So that is also important. Thyre Martin agar. So you can grow them in this Thyre Martin agar. So what does this Thyre Martin agar contains? Basically, it contains vancomycin. Okay. Now, why this vancomycin is present? Basically, it will inhibit growth of the gram-positive organisms. Okay, so that you're gonna see only the columns of the gram-negative one. Okay, then it is gonna have this trimethoprim, colistin, which inhibit growth of the other gram-negative organisms. Gram-negative organisms. Then we have got nystatin, which will inhibit growth of fungi. Okay, so basically this thiamartin-agar has basically three main drugs which will inhibit the growth of the other colonies, the gram-positive, gram-negative, and fungi, only allow the Neisseria to grow, allowing us to easily identify, okay, the colonies are growing in this agar. Okay, so this is a Neisseria meningitis thing. Okay, so that is very important for both meningitis and gonorrhea I'm talking. Currently, I'm talking the things that are common to both of them, and then I'll discuss each of them separately. Okay. Sorry. Yeah. Then there is one more agar that will be used for this one, which is chocolate agar. Okay, so which will have this hemolyzed blood. And then there is VPN agar also there, but that is not so commonly tested. And one more thing. So if there is late complement deficiency, C5 to C9, that will increase the risk of Neisseria infection, both meningitis and gonorrhea. Okay. And then what are the virulence factors? So I'll discuss that in the bug wise. So I'll start off with the Neisseria meningitis. Okay, so where does it stay? Nasopharynx. So it's going to stay in the nasopharynx. So generally in the adults, adolescents, I can say, not even adults, it can enter through the brain, causing the meningitis. Okay, and it has very specific presentation of meningitis, which can be easily differentiated from other meningitis. Okay, so how is it transmitted? So since it's in the nasopharynx, there's one guy who's having this meningitis growing in the nasopharynx of his. There are these colonies are growing in his nasopharynx. So what will happen? Because with the respiratory droplets, it can transfer to other person. Okay, 1 to 1 with the respiratory droplet. Clear? So that is about the respiratory droplets, and then it can spread to the brain via bloodstream. Using this blood, it can spread to the brain, causing meningitis. Okay. So generally, you're going to see this infection in small closed areas like college dormitories. Okay. So if you see there is an adolescent who is in the hostel or the college dormitory, and he came to you with this meningitis, the first diagnosis or the first differential diagnosis that you should have in your mind is Neisseria meningitis. Okay. If we'll talk about the whole meningitis at the end of this section, I'll talk about which age group will have which common, like the first priority meningitis, everything. Okay. But as of now, remember, young adolescent people came to the hospital with meningitis. First thing should be, like the first differential diagnosis that should be there in your mind would be Neisseria meningitis. Next, I'll be talking about the virulence factor. So what are the virulence factors that is having? One is the IgA protease. Okay, so can someone remember? Tell me what else bacterium we saw is having this IgA protease? It cleaves this IgA and allows to adhere and also colonize mucus. Colonize in mucus membrane. So in the gram positive also we have seen a few bacteria where the IgA, they are having this IgA protease as a virulence factor. Can someone tell me the name of the bacteria where we have seen IgA protease as a virulence factor?
Strep pneumo.
Very good, strep pneumo. So IgA protease is a virulence factor for three main bugs. One is strep pneumo, one is the Neisseria meningitis, another one is H. influenza. Okay, so these are the three bugs who are having IgA protease as a virulence factor. Then this Neisseria meningitis will have a capsule. So if you see this, it will be like this. This is a cocci and this is a common capsule. So that is capsule. So the capsule obviously acts as a virulence factor because of its polysaccharide. Then we have got one more thing, lipo-oligosaccharide. What is this lipo-oligosaccharide? I can write it as LOS probably. This is an endotoxin, which I think when we discussed about gram-positive bacteria, we have never seen this toxin. Okay, so this is a toxin which is present in the membrane of the gram-negative bacteria only. Okay, so when you are having activated lipo-oligosaccharide, what will happen? It will induce TNF-alpha, interleukin-1, and it will cause sepsis. This is very important. So any gram-negative bug, not only the one which I'm talking, from the Neisseria to the E. coli, any gram-negative bug, if they are causing any of the disorders, like let's say if it's the E. coli, if it's causing some UTI or some other disorder, probably the virulence factor will be Fimri or Pili in case of Neisseria, etc. But if any of the bacteria is causing sepsis, okay, any bacteria, any gram-negative bacteria is causing sepsis in the question, and they're asking for the virulence factor, then you have to think of lipo-oligosaccharide as a virulence factor. Okay, even though there will be other virulence factors for the same bacteria given in the options, if the presentation is a sepsis, you have to go with the endotoxin lipo-oligosaccharide. Okay, because this is the one that induces sepsis and causes septic shock. The same with the Neisseria meningitis. If they give the meningitis presentation or anything, the virulence factor could be either this capsular polysaccharide or this IgA protease, etc., whatever it is. But if they give you the presentation of the sepsis or the septic shock in the vineyard, then your option would change to the lipo-oligosaccharide. Okay. So this is the third one. And fourth virulence factor, be pili. Okay, so this pili is basically the one that will have multiple, what do you call it, antigenic variations. So almost they say like many lakhs and lakhs of antigenic variations will be there. Okay, so that's why you cannot make any antibiotic against this pili. Okay, you can make the vaccine against the capsule, but not against the pili because it has many variations. Okay, and what does this pili help? It will help for the attachment. Okay, and also inhibit the phagocytic uptake. So this is one of the major virulence factor of the Neisseria meningitis that you're not going to see in any other species. Okay. Then what was the clinical features? How the presentation would be? So always the presentation would be a 14 or 15-year-old male, okay, who is having meningitis like headache, all the meningitic signs being positive, etc. And also, if you see in the body, there's a rash. What is this rash? This is also known as meningococcemia with petechial bleeding. So this is basically a petechial. Okay, so they'll have this purpural or the petechial rash in case of meningitis classically. Okay, why the rash is there? Probably it will spread because of the dissemination. It spreads to the skin, causing this petechial rash. This is one very important one. Okay, very few meningitis you're gonna see rash. I think you're gonna see the rash in enterovirus, West Nile virus, and the Neisseria. We'll discuss about those in a while. But as of now, remember the rash plus meningitis in a young boy who stays in a dorm. The first thing that should be coming to your mind is Neisseria meningitis. Okay, then one more thing is there, one more complication you can say. You're not going to see this so commonly. It's a rare complication, which is a Waterhouse-Friderichsen syndrome. Okay, generally it occurs if the meningitis, Neisseria meningitis infection occurs in children or those who are not having a splenic patient. Okay, so what happens? This meningitis bacteria, it will go to the adrenal gland and it will cause adrenal hemorrhage. Okay, so when you're having this kind of hemorrhage, what the presentation the baby or the child come to is basically they'll have fever, they'll have the petechial rash. Okay, they'll have the shock because of the hemorrhage. They'll have DIC and adrenal gland failure. So it's so severe. Maximum time the child will die also. Okay, so for the treatment, you're gonna give the antibiotic therapy for the meningitis. If it is Waterhouse-Friderichsen syndrome, IV antibiotics plus fluid. For Neisseria meningitis, what is the first line treatment? Is a third line, third generation cephalosporin like ceftriaxone. Okay. For the close contacts, let's say there are 4 people in the dorm. Okay, one person got this meningitis. Since it's a life-threatening, you have to give prophylaxis to the other 3 people, right? So for the close contacts, what you're gonna give? Rifampin. I think someone was saying rifampin. If it is not available, even you can use ciprofloxacin or ceftriaxone also. But generally in the step 1, they'll test about the rifampin only. In step 2, they'll ask you about cipro or cef also. These also can be used as a prophylaxis if this is not available or if there are any contraindications are there in particular patient. Okay. Then coming to the Neisseria gonorrhea. Neisseria gonorrhea. Okay, so where does it lie? It generally resides in the genital tract of the human beings. And very importantly, the remaining everything is same. These are diplococci, they grow in the thyre martinagar. Both are, I think, yeah, sorry, one more thing I've mentioned, like to differentiate the Neisseria meningitis and gonorrhea. Generally, you don't need this in the clinical setting because meningitis the infection presentation is different, the area that it affects is different, but if it is Neisseria gonorrhea, everything, the presentation is different. In the clinical setting, you don't need to know this, but if they give any question related to the lab kind of things, you need to know one more point, that meningitis will be like can ferment both maltose, glucose. It can ferment both. If it's gonorrhea, it can ferment glucose, but maltose, it cannot. Okay, it cannot ferment the maltose. So that might be tested rarely. I don't think that is so important. I've never seen such type of questions in the final exams, in those who have given the exams. But you can say, you can have like just to, for the knowledge sake, if there is any question, there's a researcher who is doing some examination, something, that sort of question, if they want to integrate this microbiology with the biochemistry, then they might give you this question. Okay, if it's a maltose non-fermenter and the glucose fermenter, it's gonorrhea. If it ferments both, then it's meningitis. Okay, then agar is same, thyre martinagar, and gonorrhea does not have capsule. Okay, so that is important. So gonorrhea will not be having this capsule. So what are the virulence factors then? Remaining all the 3 virulence, whatever we have seen over here will be the virulence factor. One is the IgA protease. Okay. And this lipooligosaccharide. Okay. Pillin. So these 3 will be there, but not the capsule because it lacks the capsule. And what will the clinical presentation of the Neisseria gonorrhea infection? So it will have gonorrhea, So how will this gonococcal infection will be there? So you have to differentiate this from the few other things which I'll be talking in a while. So how the presentation would be, how do you differentiate this from the chlamydia infection, etc. Okay, so that whole thing I'll talk in a while. And then it can also cause septic arthritis entering into the bone. But it's not the first bug that can cause the septic arthritis. It's the second or the third, not so frequently, but it does cause pelvic inflammatory disease. Okay. Then there is one more thing called as Fitzhugh-Curtis syndrome. Curtis syndrome. Okay, so when there is a pelvic inflammatory disease, okay, if the inflammation spreads so much that it inflames the liver caps. Okay, so here you have got ovaries. Okay, so the whole tubule, the tract is being affected in the pelvic inflammatory disease. This whole thing is affected in the pelvic inflammatory, and it spread to the liver capsule. Okay, so what will happen? They'll have this kind of strands that will be connected like fibrotic strands. So the patient will have so much of right upper quadrant pain. Okay, it's basically the involvement of liver capsule in pelvic inflammatory disease in a simpler terms. Okay, so the patient will present to you with right upper quadrant pain, fever, nausea, vomiting, and remaining the pelvic inflammatory disease symptoms. So how would the pelvic inflammatory disease be present? I'll discuss this also. So they'll have this lower abdominal pain, okay, nausea, vomiting, fever, and since it affects the lower part of the, generally in the pelvic inflammatory disease, the parts that affect would be uterus, fallopian tubes, ovaries, and the surrounding tissue. Okay, so it is going to cause, since the uterus, all these things will be affected, it will cause dysuria or the urinary urgency, because it can even spread to the bladder wall, or it can obstruct the bladder wall. Okay, then it can have the pain while doing sex, dyspareunia, and also they'll have vaginal discharge. So this is how the pelvic inflammatory disease will be presented. So young female who is sexually active comes to you with pain, so much of this like pain while having sex and vaginal discharge, and also she's having fever or like infection kind of presentation. Along with this, you have to suspect the pelvic inflammatory disease. And one of the prime cause of the pelvic inflammatory disease is chlamydia and gonococcal. You need to differentiate between these two, which we'll be discussing in a while. Okay, but in the gonococcal, what we are talking over here. So if they give you this kind of presentation and they straight away they give you that it's a gram-negative diplococci, you can just go with the gonococci. Or if they didn't do any of the culture yet, based on only the presentation and the risk factors, how you'll be diagnosing. I'll be telling you in a while. For now, what will be the treatment? You're gonna give the third generation cephalosporin like ceftriaxone plus azithromycin or doxy. Generally, third generation ceftriaxone would be sufficient for the gonorrhea infection. Why are we adding azithromycin or doxycycline? Because for the chlamydia infection again. Because the chlamydia and the gonorrhea will almost always will have the co-infections. They both have the infection will comprise of organisms of both of them. Or if not the co-infection, we want to make sure like if it's the other bug, it is not missed out. Okay, so that is why you're generally gonna give ceftriaxone and also azithromycin doxy. This is for the chlamydia, azithromycin doxy. Ceftriaxone is for the gonorrhea. Okay, so this is about Neisseria, meningitis, and gonorrhea. Main differencing thing would be the capsule, the lack of capsule, and the infection pattern is completely different. That one is present in the respiratory tract and causes meningitis, and gonorrhea is present in the genital tract, and main disease is pelvic inflammatory disease. Okay. Then the third bug that I'll be talking about in the gram-negative cocci would be Moraxilla catarrhalis. Okay, so this is again present in nasopharynx. Okay, so this is a diplococci, same like the Neisseria. And what do you do? Since it's in the nasopharynx, it will cause sinusitis otitis media, all the things that could affect the nasopharynx. Or it can go to the lungs and cause bronchitis. Okay, so what are its virulence factor? One is the biofilm formation. There's one more bacteria which we have discussed which forms the biofilm. Can someone name it?
Staph epidermis.
Strep? Which group of strep?
Staph epidermis.
I couldn't hear you properly. I think you're saying epidermidis only, right?
Yes, ma'am. Staph epidermis.
Staph epidermidis. Okay, yes. Staph epidermidis. Yes, Sharanya, good job. Staph epidermidis will form the biofilm. So there also you're going to have this biofilm. And what would be the treatment? Again, you can give amoxiclav or the third generation cephalosporin like the ceftriaxone. Okay. But this is not so commonly tested, Moraxella. Rarely they might give you the presentation of the sinusitis and all the bugs they are gonna give in you in the question or in the options. None of them will be related to the respiratory tract and none of them will cause sinusitis or otitis media. Then only you are gonna go with the Moraxella catarrhalis. It is very rarely tested in your exam. But meningitis and gonorrhea, you should be all aware and clear. Okay, so you should be clear how the which from where the infection starts and how does it spread, what are the virulence factors, what are the complications, what is the treatment, how would you give the prophylactic medication. Let me just give you a question for this. Okay, so try to answer this question. Sure, yeah, I see. Let me see. Sharanya Anil said F. Guy C. F. Okay. So let us go through the question once again. It's an easy one. Okay, so there is a 26-year-old man who comes to the emergency department for the evaluation of burning with urination and purulent urethral discharge for the past 3 years. Okay, and he's sexually active with multiple female partners, so he's a sexually active. Several months ago, he was diagnosed with urethritis caused by gram-negative diplococci and received antibiotic treatment. The gram stain of the patient urethral discharge shows gram-negative intracellular diplococci. Now also he got the same infection. Which of the following properties is most contributed to the pathogenesis of this patient recurrent infection? So you gave the drug, okay, recently, but still the patient has got the infection. Why? There is a antigenic variation. There are some thousands of antigenic variation which are there in the pillars. So even if you give the antibiotic or the treatment now, tomorrow they'll develop a new strain and they'll affect you. Okay, so that's how the it would be. I think someone said C. C. The capsule will be there in meningitis or gonorrhea.
In meningitis.
Capsule, yes, capsule is seen in meningitis, not gonorrhea. Here the diagnosis is gonorrhea. Okay. So okay, so try to answer this question. FB. Okay, F is for the previous question, I guess. Okay, only Kai is answering. What about rest of you guys? You didn't understand the class. It's a straight question, right? So what is happening in this patient? There is a 17-year-old boy who is brought to emergency department because he's having fever, nausea, and myalgia. He's having high temperature and pulse is also high, whereas the blood pressure is low. It's a clear, classic presentation of shock. Okay. There is a scattered fatigue here over the anterior chest and abdomen. Blood culture is showing an organism that can grow on the thyre martin agar. Which of the following virulence factors is responsible for the high mortality rate associated with it? I have told you, whenever there's a meningitis by any gram-negative bug, meningitis presentation, not only the Neisseria, any gram-negative bug, meningitis, what is the virulence factor? It's lipo-oligosaccharides, which is a B. Good job. So, okay. So we'll get back to our discussion. So this is how the questioning would be. Either they'll ask you about the risk factors or the virulence factors or the treatment. These are the three aspects that they can ask you in the whole Neisseria. Okay. Now we'll talk about the second column. So we finished off this, right? The cocci. Now we'll talk about the Coccobacilli, which are having influenza, brucella, bordetella, and pastilla. I'll start off with the Haemophilus influenza. Influenza. Okay, so the Haemophilus influenza is generally present in the nasopharynx. Okay, and generally it is also having this aerosol of the respiratory droplet. What do we call respiratory droplet transmission? And where do you gonna see? Well, like where does it grow? It grows in chocolate agar. Okay, so chocolate agar basically contains two factors: factor 5 and factor 10. Okay, this chocolate agar, I think we have already seen, it is also used to grow the Neisseria also, the Haemophilus also, and then one more thing you're gonna see in future, Franciella. So these are the three bugs that can be used to grow. I mean, that will be generally grown in the chocolate agar. Generally, the bacteria which grows quickly or the fast replicating bacteria are grown over here. Okay. Then there is one more feature that you're gonna see in Haemophilus influenza, which is satellitism. So what is this satellitism? Okay, so if there is a staph aureus, okay, so if you place this staph aureus in a culture, okay, so it produces factor 5, right? Factor 5 via hemolysis. This factor 5 is basically the one that contains, I mean, that will be activated by factor 2A, and it acts like once it's activated, it forms this factor 10A, 5A, and calcium, which will convert prothrombin to thrombin, same like in our humans. Okay, so this factor 5 is there in case of staph aureus. Okay, so it produces this factor 5, but like when it hemolysis, sorry, it is not there in the staph aureus. When it does hemolysis of the blood, this factor 5 is released. Okay, now this Haemophilus influenza can grow in that area. Normally, another bugs cannot grow, but only the Haemophilus influenza you can see growing in those areas. So this is what we call as satellitism. Okay, understood? What happens in agar, if you place in a blood agar, if you place the staph aureus, okay, it does the hemolysis. Okay, so when it is doing hemolysis, it is going to produce this factor 5. Normally, remaining bugs won't grow over here, but Haemophilus influenza can grow in this hemolytic zone. Now we'll talk about the virulence factors. So what are the virulence factors? First factor is just now we have discussed IgA protease. Now quickly tell me what are the bugs that we have discussed till now are having IgA protease as a virulence factor? What are all the bugs? There are 3 bugs, I guess, which we have got. Epidermidis, Neisseria, and Haemophilus influenza. Okay, so these are the three bugs who are having IgA protease as a virulence factor, which can cleave this IgA and help in the mucosal adherence or colonizing in the mucosa. Then the second virulence factor that it is going to have is a capsular polysaccharide. Okay, so this capsule is basically made of this PRP, which is polyribosyl phosphate. Okay, and this is the vaccine for the Haemophilus influenza is made with this Haemophilus capsule, HIB vaccine. Now, very important. Even though the child is vaccinated in Haemophilus, okay, even the child is vaccinated, he'll get Haemophilus influenza infections. Why? Because there are many strains of the Haemophilus. Few are having this capsule and few are not having the capsule. The one who are having capsule, you get the vaccine, it will protect. But uncapsulated organisms can cause the infection. Okay. Now you may ask, ma'am, since we are giving the vaccine to protect it, so if there are uncapsulated organisms are causing this infection, why are we giving the vaccine? We are giving the vaccine against the capsule. Generally, the one strains, those are having capsule, can cause meningitis, which is a serious infection. Uncapsulated organisms generally cause infections like otitis media, conjunctivitis, epiglottitis, sinusitis, etc. Okay, so since these are not life-threatening, okay, at least we are giving this vaccine to save this to save from the life-threatening infections. So the one strain that causes meningitis, understand this one clearly. It is commonly tested one. Okay, so the strain that causes meningitis generally have the capsule. So if you give the vaccine, they'll be protected against the meningitis. But there are many other strains who doesn't have the capsule, which can cause otitis media, conjunctivitis, epiglottitis, sinusitis, etc., which can cause infection even though the child is vaccinated. Why? This vaccine is having this antigen as a capsule. Okay, so now antibodies will be formed only against the capsule. Now you have got infection for which the bug doesn't have capsule itself. What will the antibodies against capsule do? They'll do nothing, right? So that is one important point that they love to test in case of Haemophilus influenza. Okay, and then coming to the presentation, the commonest presentation or the commonest infection that you're gonna see in Haemophilus influenza is epiglottitis. Okay, so how will the epiglottitis present? So they'll have this rapid progressive inflammation of the epiglottis. Epiglottis, which will cause the patient will come to you. A child generally will have this epiglottitis who is having respiratory distress. And also the child will have this stridor, which is basically high pitched breath sound. One is this, second one is stridor. Okay, so if there is any obstruction in the airway, the sound that passes through that will have this stridor kind of presentation. Okay, you can imagine this is the pipe. If normally it's open, that's fine. If there is any obstruction now, if the air passes through that, what will happen? There is some kind of sound, right? So that is what like inspiratory stridor in simpler terms. And very important, the child will have this tripod position. What is this tripod position? It's basically where the child will have so much of respiratory distress in which they love to, lean forward while sitting. Okay, so this will helpful for them to use the accessory muscles of respiration to breathe little better. So that is the presentation, the classic presentation. They'll have sore throat since there is an infection. They'll have dysphagia, pain while they are eating food, and the child will be drooling. Okay, so they'll have muffled voice and very high temperature, like ranges from 102 to 104, and the child will be so much of restless. They will fall in heat. Okay, so this is the presentation that any child who is having epiglottitis will present to you in the clinic. And the first clinical bug that causes epiglottitis, or the first differential that you should have in your mind would be Haemophilus influenza. Okay. And we have talked about vaccine, we have talked about where it grows, what are the diseases it can cause. Now we have to know about what is the treatment. Okay. So if it's mucosal infection, okay, like sinusitis, etc., all the things, what do we call here? All this otitis media, conjunctivitis, sinusitis, epiglottitis, then you're gonna give amoxicillin or third generation cephalosporin like cefotaxime generally is preferred. Okay. But if it is meningitis due to H influenza, I'll talk about this in a while, like when we are discussing the whole meningitis. Which age group will have which meningitis in a common presentation? That all you need to know. I think in the previous question we saw the Neisseria meningitis. There I've told you about the meningitis. Here I'm talking about influenza. Here I'm talking about meningitis. When we are talking about strep pneumo, there also I've told you it can cause meningitis. So there are many bugs. You have to know what Staph aureus also we have talked. Staph aureus we have talked about pneumonia. But many bugs can cause the meningitis. You have to know which age group will have which meningitis and what are the risk factors for different types of meningitis. Okay, I'll discuss that whole thing. If it is meningitis, then you're gonna give ceftriaxone. And again, similar to the Neisseria, here also, if you want to give prophylaxis to the other people, okay, since it's causing meningitis, you're gonna give rifampin to other kids because generally H influenza meningitis occur in small kids. Epiglottitis also occur in kids and meningitis also occur in kids. When I'm talking about this Haemophilus species, I remembered one more Haemophilus bug, which is Haemophilus drusi. Okay, I'll tell you only two important things about this drusi. If there are many genital infections, there are many STIs which will have different types of presentation. But for the drusi, remember, you do cry with drusi. You'll understand why I've told you this because you have to be able to differentiate different genital infections. Okay, so they'll have big, painful genital ulcer and painful suppurative lymphadenopathy. Okay, here you can see here that the ulcer also this patient who is having is a painful and lymphadenopathy also. So that's why you do cry with drusen because it's so painful. Okay, if you say syphilis, okay, syphilis also will have lesions, syphilis also will have lymphadenopathy. There will be no pain in syphilis. HSV will have small genital ulcer, not this much big, very small lesions, but they don't have this painful lymphadenopathy again. Okay, I'll tell you that flowchart also, how you need to identify different STIs, okay, at the end of probably microbiology or at the end of bacteriology. But as of now, remember, DOSI will have only one important presentation, which is STI. This presentation is known as chancroid. Don't confuse this with chancre in case of syphilis. Okay, here you're going to get this chancre, which is basically painful genital ulcer with the painful suppurative lymphadenopathy. And for the treatment, they don't even ask for you for the treatment in drusen. They want you to diagnose that as a Haemophilus drusen. Okay, that is the maximum expectation. If they ask for the completion sake I'm giving, you can give them macrolides like azithromycin or the third generation cephalosporin like ceftriaxone. Okay, so that is about the Haemophilus species. Influenza and drusen. Is everything is clear? Like regarding this vaccination part and everything, because this is important and this is always like the frequently tested part as well. Why, even though after being vaccinated, the child is going to have the infection again. Okay, so if you are clear, I'll move to the next bacteria, which would be Brucella species. All right, so I'm moving to the next one, which is brucella. Okay, so these are basically a very small gram-negative. Okay, remember all the bugs which we are discussing today are gram-negative. Okay, gram-negative rocks. They are aerobic, and they can be inside the cells or outside the cells, so they can stay in both the things. That's not the main question. The main question is how do they transmit? And brucellosis, main maximum times they want you to know the mode of transmission. Okay, so how do they transmit? Unpasteurized dairy products. Pasteurized products. And a quick question, deli meats, and I think there also we have talked about unpasteurized dairy products can cause infection with one more gram-positive bacilli, which we have discussed earlier, and generally is avoided in pregnant women. What was the gram-positive bacilli? It also spreads to the unpasteurized milk and dairy meats. It is avoided in pregnant women. Remember from the previous session? I'd be so happy if at least one remember it. And milk products, dairy meat, not exactly unpasteurized milk over there. They generally say any of the milk products or the dairy meat can transfer that bug. And it is generally completely contraindicated in pregnant women. It has a tumbling motility. Someone remember it? Tumbling motility, contraindicated in pregnant women. Spread through the milk and milk products, like the cheese also. No one able to recall. It starts with L. Yes, yes, Listeria. Listeria monocytogenes. We have discussed the other day, right? So it will have tumbling motility. It generally have the risk, like it's generally transmitted to the milk and milk products. And if the pregnant woman gets it, and the child will have so much of severe listeriosis, which will affect the meningitis, the whole. It's a complicated presentation in a child. So it's generally, if it's an adult, normal, healthy person, they don't have much so complicated. But pregnant lady, if she takes, the baby will have such presentation. So it's completely those type of food, all those things are avoided in pregnant women, right? So microbiology would be like this. So you know all the things, but we forget the risk factors, the whole things, mode of transmissions, etc. So what is the solution for that? Is basically you need to revise those stuff regularly. Whenever you get time, one day like weekly once, or sometimes one day you read the gram-positive bacteria, other day gram-negative, other day fungi, other day virus. But you should be keep revising all the the microbiology regularly. Otherwise, you'll forget. Once you revise them like 5 times, 10 times, what will happen? Since this is completely memorization, the microbiology, it will be in your the permanent memory, and then you don't need to revise at all. Without revision, also you can go to the final exam. Okay. Until you get into that stage, you need to be revising. What are the risk factors? How will they present it? And very importantly, microbiology will be covered in step 2 as well. In step 2 also, you're going to have a very huge topic, which is an infectious disease, which is completely microbiology. There is nothing extra over there. Little bit treatment might be increased. Other than that, you need to identify same like the step 1. Okay. So revise those things, revise the risk factors, revise the mode of transmission, revise what are the virulence factors, the treatment. Maximum they'll test you with the 4 things for every single bug. For bacteria, for virus, for fungi, for all the things. Okay. So coming back to our thing, brucella. So the main common mode of transmission is basically unpasteurized dairy products. Okay. Generally, those who are having in contact with animals like the vets, or farmers, or those who work in the slaughterhouse. Okay, right? They are the ones that have direct contact with animals, so they are the ones that will have increased risk. Okay, so now how will the presentation? What was the clinical presentation of this brucellosis? So the clinical features would be they'll have some fever, which has given a nice term, undulant fever. Okay, so this undulant fever is basically, so they'll have this acute septicemia, so acute attacks of the septicemia. Okay, fever will be there in the evening. and morning they'll be fine. And then for 3 days, for 1 day they'll have fever, 2 days normal, and third day they'll have fever. That also can be there. Okay, and also they'll have this influenza kind of symptoms like myalgias, back pain, arthralgias, etc. Like bone pain, muscle pain, and back pain. When you see this, generally we think of the viral infection, right? Because that's where you're gonna have normal symptoms. That's where they have given this influenza type of presentation. So generally they'll have this brucellosis is seen in veterinaries, farmers, or the slaughterhouse people, and they are old people. Okay, they are generally the old people. So they'll have this cyclic bouts of depression and sweating. Yeah. And very important complication is basically osteomyelitis. And we are going to see few more bugs which will have osteomyelitis. It's a complication. Like in the salmonella also, you're going to have this complication of osteomyelitis and few others which we'll discuss later. Okay. So that is about the brucellosis and the treatment. Rifampin plus toxin. In child, generally you avoid tetracyclines, okay, because of their effect on the bones. That's so in child, you're going to give rifampin plus Hortomox. And how do you prevent it? Pasteurize the milk, vaccinate the animals, so that's how you're going to prevent the spread of this whole thing, okay? Yeah, so that should be about the brucellosis. Then we'll discuss about the third bug over there, which is Bordetella. And this is also one of the board's favorite bug, Bordetella. Maximum times you'll get one question in the Bordetella pertussis. I don't know why, but the board loves this. So what are this? Where do they reside? They reside in any part of this human, generally the oropharynx, and they'll be grown in a particular agar, which is Bordet Genjo agar. This agar contains potato, blood, and glycerol. Okay, so this agar is used to grow this Bordetella. You're not going to see any other organism growing this agar, only the Bordetella will be. Okay, and what are the toxins or the virulence factors? Toxins. First toxin is this is for the one that is having capsule. Then you have got one more toxin, which is pertussis toxin. Okay, so what does this pertussis toxin do? It is an AB exotoxin which has. Okay, so what it does is basically. So first I'll tell you what the Bordetella pertussis does, like what is the normal pathology, and then I'll tell you what this toxin does. Then you'll understand. So once this Bordetella lies or infects the ciliated epithelial cells of the respiratory mucosa. So these are the cells. Okay, now the bug Bordetella came over here. Okay, so once it comes over there, it is going to produce few toxins like a tracheal cytotoxin. What it does, it paralyzes the cilia so that they cannot move, and also it causes inflammation. Okay, so this inflammation will be secreted into the respiratory tract. So now this is the epithelium. Okay, so it paralyzes the cilia so that it cannot move, and also what else it does? It causes some secretions to accumulate over here, which will block small airways. Okay, when you block small airways, what will you have? You're gonna have cough, pneumonia. Okay, since you're not having enough perfusion, you'll have cyanosis. Okay. Now, what does this AB exotoxin or the Bordetella pertussis toxin does is basically it does ADP ribosylation of alpha subunit, the whole thing of GI protein. Okay. Normally, this GI protein is the one that that does the inhibition. Okay. So if you do this ribosylation, what will happen? You will be inhibiting this GI protein. Inhibiting this GI protein. What will happen? You'll have continuous stimulation. There is no one to inhibit this camp. Okay, so the camp will be accumulated. So there is increased stimulation causing continuous cough and everything. Okay, continuous muscle movement and everything. Understood? So what will happen? So this toxin will go and it will inhibit the inhibitory protein. When you are inhibiting the inhibitory protein, what will happen? You'll have so much of stimulation causing like the whole cough and everything. What it does, it basically goes into the respiratory tract, it lies over the epithelial cells and it produces all its virulence factors and it paralyzes the cilia, and also the inflammation will be released, which will cause blocking of the clogging of the small airways, and also they'll have this cough, pneumonia, cyanosis, etc. Okay, so that's how the presentation would be. And if I want to talk about in detail, there are basically 3 stages of the pertussis. One is the catarrhal stage, okay, which will last for 1 to 2 weeks. Generally, the patient don't come to you at this time because they just have the cough and they just have the fever. Okay, that is also normal cough. Then the second stage is paroxysmal stage. So here you'll have bouts of cough. Okay, so they cannot stop coughing even during night. So this is what paroxysmal coughing is. And also they'll have this what do we call high pitched whooping sound because the airways are being blocked, right? So when you're trying to inhale the air, you'll have this high pitched whooping kind of sound. So high pitched whooping sound. And also they'll have vomiting because you have cough so much and you have vomiting. So because of this whooping sound and cough, this is what is known as whooping cough. The other name for the pertussis infection is basically whooping cough. So they'll have bouts of coughing which is so severe, and they'll have this whooping kind of sound. Okay, the third stage is basically convalescent stage, so they'll recover. Okay, generally the presentation, the patient will never come in the first stage. Obviously they are not going to come in the third stage. So they'll come in the second stage, which is the paroxysmal stage, where the patient is having so severe cough, and they'll tell you the patient is having cough since 2 or 3 weeks. But if you ask why you have come now, first week or the second week, the cough is not so severe. It's just the normal cough. We thought some viral or the bacterial infection, so we didn't come to hospital. Now it's so severe that I cannot sleep, I cannot eat, I cannot do anything. So that's why we'll visit to the hospital. Okay, so that is how the presentation will be. And how will you diagnose? You're gonna do this thing. What do we call? You're gonna ask the patient to cough in a cup. Okay, so this is the some cup or some plate. You're gonna ask him to cough. All the bacteria will be there. You're gonna do the culture and confirm. Okay, so this is the pertussis. Okay, so that's how you'll be diagnosing it for the treatment. Oh, sorry. For the treatment part, you can give them macrolides like azithromycin, erythromycin, etc. So you can give any of those macrolides. So how do you prevent this? First one is you're going to give them vaccine. Very important. Vaccination is generally this brucella vaccination. This is not there in India. Oh, sorry, not brucella, bordetella. So this vaccination is not there in India because we don't have that much of prevalence in India. But in US, it is there in the immunization schedule as well, bordetella pertussis. So you're gonna like, how will you prevent this or something? If that type of question is there in the exam, you have to choose by vaccination. There's no drug for the prevention. Drug is only for the treatment. That's about the third bug, bordetella. So far we have discussed about the Haemophilus influenza and brucella and bordetella. Now I'll discuss about one more bug, which is Pasteurella. Pasteurella multicoida. Okay, generally it is there in dogs and cats. Okay, so it's generally So those who are having this dog or cat as a pet, if it bites, okay, they're having cellulitis after 1 week or after few days, you're gonna think of Pasteurella. Simple. Okay, dogs or cats, they're having this as a pets. They did the bite and they're having this cellulitis presentation where there is swelling, so much of pain. If there's small bite also, the whole lip will have swelling and pain and everything. Okay, so then you have to think of this Pasteurella. You don't need to know. There are risk factors. Sorry, there are virulence factors. The whole thing, but they'll never ask you about any of those in Pasteurella. They'll ask you about the diagnosis, or maximum they'll ask you about the treatment where you're gonna give either amoxicillin or the fluoroquinolones, like the ciproflox or the cipro. Okay, so this will be tested. So try to answer this one. This 18 month old boy. Try to answer that question. Someone answered epiglottitis. It's a changoid, epiglottitis. Okay, so let's see what's happening. There is an 18-month-old boy who's a small boy. Is brought to emergency department by his babysitter because of the lethargy and fever for the past 3 years. He has not recovered from a middle ear infection, so he is having otitis media. Now he is having high temperature, nuchal rigidity. So that means from the otitis media, he has developed a complication of meningitis. The pathogen that is isolated from the CSF does not grow on the blood agar, but when co-cultured with the staph aureus, it grows. So this is what we call as satellitism. Vaccination also prevent against which of the following conditions. So this patient is having Haemophilus influenza meningitis. That is clear. And the question is, if you vaccinate, it can also prevent which of the following conditions. I think I've told you, generally the strains that cause meningitis will have the like the capsule, okay? But the strains that can cause sinusitis, bronchitis, pneumonia will not have capsule, okay? But I think I forgot to mention epiglottitis strain, the one that causes epiglottitis, can have capsule. Okay, like both the strains can cause epiglottitis. Am I clear? So either if you give the vaccine, it can prevent epiglottitis, but not 100%, because there are some strains who can cause epiglottitis who doesn't have the capsule. So it's like the half of chances. So here the answer would be epiglottitis. I hope I'm clear. All right. So all right, try to answer this question as well, so that you'll get a clear idea of what I'm talking about in the vaccine part. Don't get confused. The strain that causes meningitis is definitely capsulated. That's why you have developed a vaccine against the capsule. All the strains that causes the mucosal infections are not capsulated, but few strains that causes epiglottitis are capsulated. So they can sometimes prevent the epiglottitis, but not 100% sure shot. Clear? So try to answer this question as well. Sorry, got changed. So five answer it. Okay. What about the rest of the students? You didn't get the answer it. Here, let me see. Sanvi Arora, I think you were there in the previous classes as well. So try to answer it, ma. Nandita, Sahiti, and Sharanya, Ushasi. What this name is. All right, so we'll go through this question. What is happening over here? 3 years old boy is brought to a physician by his mother because he's having headache, fever, and facial pain that started almost 10 days ago. Initially improved but got significantly worse over the past 2 days. He's having no illness, immunizations are fine, he's having temperature which is high. Examination showing tenderness to palpation of both the cheeks. Gram stain shows small gram-negative Coccobacilli, which are the following likely accounts for the patient infection with the causal organism. So he is immunized, right? So he shouldn't be having Haemophilus influenza infection. Okay, why? Because he's immunized. But generally, again, the same thing which we have discussed. He got epiglottitis. Okay, so the organism that caused him is not capsulated. Okay, so that's why. Sorry, not epiglottitis. He got sinusitis. What the sinusitis, which is caused by Haemophilus influenza, which is not capsulated, so the vaccine cannot prevent it. Okay, so that's how it will be tested in case of Haemophilus. So, any doubts you're having regarding this Haemophilus influenza, Drusi, brucella, or the Bordetella? Or shall I move to the next segment, which is gram-negative bacilli?
Ma'am, is it maxillary sinusitis?
I didn't understand your question, Kaif. Can you come again?
Ma'am, is it maxillary sinusitis?
Which type of sinusitis you're asking? Maxillary? Yeah, probably because he's having tenderness in the cheeks and face. Probably that's a maxillary one. Okay. So we'll move to the next part where we finished off Cocci and Coccobacilli. Now we'll discuss about the gram-negative bacilli. I'll start off with this segment, which is having E. coli, Yersinia, Shigella, Salmonella, Klebsiella, Proteus, and Serratia. Okay, they are all will have kind of similar virulence factors, everything. So they are categorized as in the similar one, which basically belong to the same family, Enterobacteriaceae, all these things. Okay, so we'll discuss all of them once. First, I'll talk about E. coli. Okay, so E. coli are again a gram-negative bacilli. Okay, who can ferment lactose. I'm talking about fermentation of lactose. Why? Because generally this is one point that will be given in the question to help you to understand. Okay, this is E. coli. Since it can ferment lactose. When it grows on the McConkey agar, it can turn the colonies pink. Okay. It also can cause green color sheen on EMB agar. I'll talk again why we are talking about this green sheen on the EMB agar. There's one more bug which can cause a different color in the EMB agar. EMB is basically eosin blue agar. Okay, here it will cause green sheen. McConkey pink. So if you see these two things, green sheen in the EMB agar, pink color in the McConkey, probably they are talking about the E. coli. Then this bug is catalase positive. Okay. Again, this is a facultative anaerobe, so wherever you want, it can go. Okay. Then where can it general? It's present in the colon, and it can also be there in the vagina or the urethra. Okay. So what are the clinical features or the clinical diseases that it can cause? Okay. So what are the clinical diseases that it can cause? I can say clinical presentation. First thing it can cause, it is the primary bug of UTIs. So whenever you see the UTI in female, generally first thing would be the E. coli, unless they give you a specific risk factor for any other bug. So it is the primary cause of the E. coli. Okay. So since it is there in the colon, okay, it's in the fecal flora. The female will have a short urethra, so it can contaminate and ascend into the urethra and can cause UTI. Okay. And what is the main virulence factor that allows for E. coli to cause UTI is basically fimbriae or pili. So what does it do? It helps the E. coli to adhere to the uroepithelium and to, move across the ureter or the move across the ureter and is causing the UTI, not ureter, urethra. Sorry. So this is the primary one. Then it can cause neonatal meningitis. Not as a primary bug. The primary one that causes neonatal meningitis is Haemophilus influenza. So E. coli will come as a second most common. Okay. Because why? Because the baby will be delivered from the maternal, reproductive tract, right? So if there is some fecal flora that can contaminate during the paturation or while like baby is being delivered, it can cause this meningitis. Okay. So what is the mechanism? Here the bacteria capsule will be acting as a virulence factor. So bacteria capsule will have this K1 serotype antigen which acts as a virulence factor over here. Okay. So again, it can cause sepsis, E. coli sepsis, very common. As we have already discussed, whenever the sepsis, what is the virulence factor? Sepsis by gram-negative bacteria, what is the virulence factor?
Lipol.
Very good, lipooligosaccharide. So that would be your major virulence factor if there is any sepsis. Okay. So that's why I've talked about, along with the clinical presentation, along with the virulence factors. Okay, so this virulence factor will be the useful in this kind of presentation. Let's say UTI, Fingria will be helpful for them. Let's say meningitis, K capsule will be helpful for them. Let's say sepsis, lipooligosaccharide. Okay, so let's say they have given you a presentation of sepsis. Okay, and they have given you options of Fimbriae, K capsule, and lipooligosaccharide, etc., etc., etc. And they have asked you, this patient is having this kind of presentation due to the presence of which are the following virulence factors. Of course, all the three are the virulence factors of E. coli, right? But when we are particularly talking about the sepsis, what could be the correct one? The correct one should be the lipooligosaccharide. So that's how you should be able to answer. Okay. So in the E. coli, there are many strains. Okay, enteroinvasive, enterohemorrhagic, enterotoxigenic, and there are few others, enteropathogenic, enteroaggregative, etc. But the most common one that you need to know for your examination would be enterotoxigenic E. coli, enterotoxin E. coli, and the enterohemorrhagic E. coli. Enterotoxin E. coli is the one that causes traveler diarrhea. Okay. So generally, it will be transmitted by the fecal-oral route. And it causes so much of watery diarrhea. What is the mechanism? If they give you the E. coli diarrhea, okay, this is the fourth one. What is the risk factor? What is the mechanism? So here it will have a certain toxin. It will have two toxins. One is the heat label toxin. This is the first toxin. And the second toxin which it have is a heat stable toxin. Label toxin is the one that stimulates adenylyl cyclase. So when you stimulate adenylyl cyclase, what will happen? You'll have increased motility, which itself explains why the patient will have diarrhea, right? And then you have got second toxin, which is stable toxin, which stimulates guanylyl cyclase. This will help in increasing absorption of the chloride, water into the small intestine, causing diarrhea. Okay, so these are the two toxins. Let's say there is a question about the traveler diarrhea. Okay, so they have given you a presentation of diarrhea. No, the risk factor probably just a normal diarrhea in a healthy adult. Thinking of this E. coli again. Okay, now they're asking what is the witness factor of it. Then you shouldn't go with fimbriae. You shouldn't go with K capsule. Even, not even the lipo-oligosaccharide. The correct answer would be either the heat label toxin or the heat stable toxin. Okay. Then you have got the second strain, and which is basically enterohemorrhagenic E. coli. So this generally is transmitted. This one I've told you the fecal-oral route, right? So this is transmitted in undercooked meat. Okay. So it causes bloody diarrhea. Not watery one, like the enterotoxigenic. Okay. So, but it is not inflammatory, so the patient will not have any fever or any pus, but they'll have the bloody diarrhea. Okay. So what happens? There is this toxin which goes, and the exact toxin name they Shiga-like toxin. Why? Because the toxin behaves similar to the Shigella. So what this toxin does is basically it inhibits the protein synthesis by interfering with the 60S ribosomal subunit. Okay, so when it inhibits this kind of protein synthesis, what will happen? The cells will die, the mucosal cells will die, which will cause the bloody diarrhea. Okay, so they'll have this diarrhea also, they'll have the blood in the diarrhea as well. The most common serotype that causes this is 015787. So this is the common phenotype that causes enterohemorrhagic E. coli. And very importantly, they'll give you the thing that they went to some party and they eat some meat which might be like uncooked or etc. Okay, so they eat the meat etc. Okay, and then so that's about the Shiga-like toxin. What else we need to know? Yeah, so they should be fine. And for the treatment for the E. coli, generally you're not going to use any of the antibiotics. Okay, why? Because this is the diarrhea, so you're gonna give the oral rehydration. Rarely, only that too, only for the introtoxigenic E. coli, you can use ciprofloxacin. But that is also not so commonly recommended. Generally, fluid replacement or the supportive therapy should be fine. Okay, rarely you're gonna give Cipro or the TMP SRS. But for the hemorrhaging, nothing, you can give nothing. And what is the complication that the patients might get in the enterohemorrhagic E. coli? One complication you gotta see would be hemolytic uremic syndrome. Not the hemorrhagic one, even the toxic one also. Hemolytic uremic syndrome. Okay, so that is the one complication you're gonna see in case of hemorrhagic one, not toxic. Hemorrhagic one. So what will happen? There will be this microthrombus formation, okay, in case of this enterohemorrhagenic E. coli infection. which can occlude these capillaries. Okay, occlude the capillaries. So it will cause anemia. Okay, and it will cause thrombocytopenia because the platelets are the one that are forming this thrombus, and it will cause AKI. And very important, you should be able to differentiate from this from TTP, thrombocytopenic thrombocytic purpura, right? So that is one which we'll be discussing in the hematology. So I'm not going in deep about that, but just remember, in whenever they want to give you this hemolytic uremic syndrome as a presentation, so they'll give you the patient is having diarrhea a week or 2 weeks ago, which resolved on its own, etc. Okay, so that's about the immunogenic and so the E. coli to E. coli can cause capsule. It can cause sepsis where the virulence factor would be oligosaccharide. It can cause traveler diarrhea, okay, where the virulence factors would be libel toxin and the stable toxin. It can cause bloody diarrhea as well, where the virulence factor would be Shiga-like toxin. And what is the treatment for if it is any of this? Okay, UTIs, meningitis, sepsis, etc. All these things, you're gonna give ciprofloxacin and trimethoprim sulfamethoxam. If it's diarrhea, you're gonna give the supportive therapy and the oral rehydration therapy. Let's see how this will be tested because E. coli is a huge one. I want you to. Okay, so take a moment and go through this question. Can we stop it? Okay, so you guys are tired. So shall we continue this class tomorrow or after this E. coli, or shall we finish this off the all of the bacteria?
After equalize tomorrow.
After E. coli, you want to end the session? Okay. Right. Tomorrow's session would be very big then. From 6 to 9 we need to have the session because there are many bacteria that need to be discussed. All right. As of now, answer this question. It's a simple question, guys. Try to answer this. After all this discussion, you should be able to answer it. Sanvi, PNV, Nandita, Saiti, Ushasi, and Kaif. Fimrie. Okay, so let's see this question. What's happening? There's a healthy 26-year-old woman who comes to physician because she's having 2-day history of pain with the urination. she's sexually active and she's having two partners, she uses condoms, everything is fine. There is suprapubic tenderness, and urine analysis is showing neutrophils, so probably a bacterial infection. Positive nitrite test, and there is a gram-negative oxidase negative rods. Yeah, I forgot to mention E. coli is oxidase negative. Okay, that forms greenish colonies or the EMBR, green color colonies. I think I've told you green chin on the EMP. So that is all of these are pointing towards one thing, E. coli. So what is the E. coli causing over here? UTI. Now what would be the virulence factor? That is Fimbi. Very good. So try to answer this question.
Heat labile toxin.
Very good. Heat labile toxin. So what's happening over here? Again, there's a healthy man who is having abdominal pain, vomiting, and watery diarrhea. And non-bloody diarrhea recently came from a trip. Okay, so probably a traveler's diarrhea. There is a gram-negative rod-shaped bacteria that ferment lactose. Okay, so which of the following is most likely to be involved in this pathogenesis in this patient? So it is heat labile toxin. So I think this is about E. coli. Yes, so this is how the questions will be tested, or they can ask you in the UTI part. Generally, they can ask you for the treatment where you have to go with any of the fluoroquinolones. Okay, that will be there in the UTI. And as you can see, how to highlight or read your questions also. How you can follow like how I'm reading it. So you can see first we are looking at about the age. The next point that you need to look at is the presentation or the chief complaint with what the patient gets. And in the next 4 lines, the stem, you need to look for 2 points, either abnormal vitals or the other thing that you can look is the risk factors. Here, one thing I found is abnormal vital. Okay, I didn't find any risk factor. I just found abnormal vitals. And then the last part, you have to look for the examination. So if you are able to identify these 4 points correctly, you should be able to answer all the questions. This is what I tell to all of my students. I think whenever we having one-on-one sessions, I always tell you guys this, whoever attended my one-on-one sessions. So first thing you need to highlight, look, is age and the sex. That will give 10 to 15% of the diagnosis. Next thing is the chief complaint. Next, in the whole stem, you have to be looking for 2 things: abnormal vitals or the risk factors. In the bottom line, examination point, and then if you put all of them together, maximum times you'll end up with the correct diagnosis if you're having enough knowledge. Those whoever is having that question reading problem or anything, they should be able to solve them. Okay. All right, then